Welcome to the MedEvidence podcast. This episode is a rebroadcast from a live MedEvidence presentation.
Yes, thanks for coming. So while you're nourishing your bodies, we're going to exercise your brain a little bit by starting out with some questions to get you thinking about migraines. Okay, so which of the following statements is true about migraines? A migraine is just a really bad headache. A migraine aura is your brain's way of previewing the next episode of reality. People with migraines have a secret antenna that picks up bad weather forecasts a day early. Now, some of you with arthritis will say that is definitely true. Or, currently, there are no cures available for migraines. Anyone want to venture a guess?
Yeah,
First in the D, I hear.
It's the last one that currently we don't have a way to make someone who is a migraine patient not be a migraine patient. Migraine, it turns out, is a polygenetic disorder. Some 30 to 35 genes that are involved, and if we happen to inherit the right set of genes and in the right environment, our brain becomes capable of making what happens in a migraine occur. And while there are not cures for that, there are a tremendous number of extremely effective therapeutic options that help us significantly mitigate the impact of migraines on patients' lives. The secret antenna one I think is funny. It is actually one of the most common things that migraine patients will tell us, that they can actually predict when they're going to have a migraine event when barometric pressure changes are occurring, particularly the dropping phase of it. And so there's not really an antenna that's there, but there probably is potentially something for us to discover. We know almost nothing about that, though.
All right, and to bring you back to your school days of multiple choice questions, which of the following are possible symptoms of a migraine attack? A, nausea and vomiting. B, sensitivity to light, also known as photophobia. C, sensitivity to sound, also known as phonophobia. D, a persistent fever. E, A, B, and C. But there's also F, all of the above. Okay.
You were saying it correctly.
I heard E.
Hit it one more. I think it says.
There's A, B, and C.
So those are the symptom complex: nausea, vomiting, light, sound sensitivity, particularly that make people think something is migrainous. But not everybody has these symptoms. 80% of people will be light sensitive, and so just because someone does not have light sensitivity does not mean that the headache is not a migraine. But those are extremely common accompaniments. So I think we can move on from that.
Okay, so let's get into what are migraines.
So this is the World Health Organization's definition, a primary headache disorder that is in most cases episodic, usually lasting between 4 and 72 hours with the things we just mentioned: nausea, vomiting, photophobia, and phonophobia. Sometimes preceded by the aura phase of a migraine that we'll talk a little bit more about in detail in just a little in a subsequent slides. A couple of words about the first sentence there, a primary headache disorder. We categorize headaches and split them into two broadest categories: primary and secondary headache syndromes. Secondary headaches have a cause that can or needs to be identified. The example that I give to patients is a silly example. If somebody hits you in the head with a brick, that would hurt. If they did it every day, it would hurt every day. We could give you all the headache medicines on the planet. It would not fix that problem. You would have to figure out that somebody's hitting you in the head with a brick and ask them to please stop. Now, primary headache disorders don't have a cause that can or needs to be identified. That doesn't mean there's not a cause. I alluded to the genetic cause earlier. It's just that you can't identify the cause for primary headache disorders, and you don't need to because there's nothing you can do about that. And that's very frustrating for patients and family members who suffer from a recurrent, oftentimes extremely severe headache complaint, and nobody really explains to patients what the cause is. And so with migraine being by far the most common severe primary headache disorder, the most common primary headache disorder is tension headache, but the most common severe one is migraine. It's helpful for people to understand the difference between primary and secondary headaches. And so we don't necessarily need to be searching for the cause for why somebody gets migraines. People just get them.
All right.
Yeah, sure.
Okay.
You want me to keep going?
Yes, please.
Okay. So when we look at the frequency, some epidemiologic information about migraines, it's important for us to understand that less than 50% of people with migraines ever go to the doctor and actually ask for help. And so most people with migraines are never diagnosed with migraines. 90% of people affected have some pretty severe impact on their life. In the United States, one of the more recent estimates on the frequency in the US is more than 39 million people have migraines. One way that I think is useful to sort of think through the epidemiologic information with migraines is to understand how frequently the disorder is present in men and women, because it's a little more frequent in females than in men. It's 2 to 3 times as frequent in females. 1 in 5 females is a migraine patient.
That takes us time to our next slide as well.
Yep, and 1 in 10 males is a migraine patient. And so if we are experiencing headaches and you are either a male or a female, if they are bad headaches, as long as they're not a secondary headache syndrome, you're very likely dealing with migraines. The American Migraine Prevalence Study, which is a little bit of a dated study, but it is actually our more recent epidemiologic studies are not too different than the data that came from AMPP. 50% of severe migraineurs, never had a formal diagnosis of migraines, and that's a mixture of things: not going to the doctor, doctors not asking about the problem, and then oftentimes being misdiagnosed, actually. The next statement that says 12% were in the American Migraine Prevalence Study were on adequate preventive therapies in the eyes of a headache specialist. That is 12% of patients who we would suggest need to be on preventive medications. 12% of them were on preventive medications. And so that's just a data point pointing out how we are really not adequately taking care of migraine in the United States based on that report card.
And since you mentioned, migraines are underdiagnosed and sometimes even misdiagnosed, do you want to say a little bit about something we've talked about with patients saying, I have a sinus headache, I don't have migraines?
So that would be something that you would have come across frequently
Yes.
in a family practice. I mean, the data on it are 85% of what a physician has diagnosed as sinus headache. 85% of that is all migraine. Of course, sinus infections exist. They do. But I gave you the statistics on diagnosis of sinus headache is almost all migraine. And that's a good example of, and one of the reasons why we very frequently have referrals to the headache clinic from ENT physicians who say there's nothing wrong with your sinuses. This is go see the headache doctor. But that's only true of some headache or some ENT physicians. Some ENT physicians just say there's nothing wrong with your sinuses, and then don't follow through with to go see the neurologist. So that's a good point.
All right.
This is kind of a funny one. When I get a migraine, I always follow the aspirin label, take 2 and keep away from children. Go to the next one. I think that, this slide is here to kind of make a point that there are a variety of reasons. There's a list of reasons why patients don't go to the doctor and complain about headaches, and why doctors don't necessarily ask about headache disorders. And one big piece of the puzzle turns out to be the stigma that surrounds a migraine diagnosis. Historically, with the little funny business over to the side, that's actually a commercial, a marketing piece. When boredom and emotional fatigue bring on housewife headache, it's actually an advertisement for aspirin, Anacin. And those sorts of biased approaches, viewing a migraine patient as perhaps having something emotionally wrong with them, I think has been ingrained in our society for generations, actually. But we need to, and it is appropriate to think of migraine as a brain disease. It is a brain disorder. We understand it very well, and it is every bit a brain disease as Alzheimer's or Parkinson's or multiple sclerosis.
Yes. And aren't we glad that research has taken us away from the housewife headache? My husband and I had a good laugh about that last night. So.
Yeah. All right. So it sort of jumped into a little bit of a different topic. Obviously, migraine is more common in females, and one of the more common scenarios that a person is actually likely to seek help is when migraines are tied with menstrual periods. You probably experienced quite a bit of that with your family practice patients.
Yes, and fortunately, just like we talked about with sometimes being misdiagnosed, is young women will think it's PMS. It's just PMS. It's just part of what I have to go through every month.
I would ask you a question when seeing a young female who is having trouble with premenstrual symptoms, and a lion's share of that is the headache complaint of it. Be honest, internally, do you sort of think, oh brother, this is going to be tough?
It's going to be tough. It is tough because you're asking patients then to track their periods, track their headaches, track all their symptoms, which is the last thing they want to do at that time.
Well, the menstrual migraine clinical scenario is a difficult one. The problem is the fluctuations in hormones that are occurring primarily at the beginning of menstrual flow, but also on day 14 where ovulation occurs. The swings in hormones that are occurring just turn out to be a really good way to trigger what is capable of being triggered in the brain of a migraine patient. And while it's a prominent trigger, that trigger is sustained. That trigger, the hormone swings that occur are sustained for days and days in a row, usually several days in a row. And so to get that migraine process to shut off has historically been quite challenging because it's a prolonged exposure to the trigger. We do have a handful of unique approaches to specifically deal with menstrual migraine, and it is actually very specifically one of the topics of a currently ongoing clinical trial at Jacksonville Center for Clinical Research, and we're certainly a part of, and we're excited about participating in that because the menstrual migraine patient is a challenging patient, and while we have several things that we know of that can really be helpful, we need to expand that medicine cabinet up a little bit to help patients with menstrual migraine.
So now that we've talked about one of the subtypes, let's talk about how are migraines diagnosed?
So, when you went through training, did anybody ever talk about diagnostic criteria for migraine?
Very little.
Yeah.
Very little.
I would be surprised if at all. So, in 1988 was the first time that the International Classification of Headache Disorders was devised by a handful of really expert, lifelong headache specialists. And headache diagnostic criteria exist in this body of literature. Its name is the International Classification of Headache Disorders. You'll see it says ICHD-3. It's been revised 3 times now since 1988. And it is a set of diagnostic criteria for all of the headache disorders that humans experience. And so this is just the listing of migraines diagnostic criteria. So the first is that a person has had at least 5 attacks. And the reason that 5 attacks, it really says it's 5 attacks over a period of at least 6 months. That's really addressing the possibility that the patient in front of you is a secondary headache syndrome patient. If somebody's been having a recurrent problem for 6 months, they probably don't have a hemorrhage in their brain or something like that. It's been going on for 6 months. And so the duration of it, I think, is how long the syndrome has been present is actually part of the criteria. It turns out that how long a headache lasts turns out to be a really diagnostically useful piece of information. Migraine untreated or unsuccessfully treated is almost always going to last between 4 hours and 72 hours. So up to 3 days would be pretty typical of a migraine syndrome. The characteristics that you see listed under C, this is where I think a lot of confusion arises. So the characteristics of being on one side of the head, unilateral, pulsating in quality, moderate or severe in pain, and aggravated by routine physical activity. It makes people need to avoid routine physical activity. You need to have 2 of those. And so if something is moderate or severe in intensity and is pulsating and throbbing, it can be anywhere on your head. If it's unilateral and pulsating, it doesn't actually need to be moderate or severe. It could be mild. And so you really just need 2 of those to be positive or present for us to satisfy diagnostic criteria. Then lastly, under D, nausea or vomiting, or light and sound sensitivity. We have a lot of confusion with light and sound sensitivity as well. The light sensitivity, as an example, exists in a spectrum. There are some people in the midst of a migraine who are so light sensitive, they have blackout curtains, they've shoved towels in the cracks of the door so there's no light coming through underneath the door. They're laying in their bed with the pillow over their head and it's still too bright. There are some people with migraines who, if they look at a fluorescent light, will notice, it's just a little bit more comfortable. I agree, it is a little bit more comfortable. That's light sensitivity. Actions speak louder than words often in this situation. A lot of times people will say, no, I don't have migraines. I don't have any light sensitivity. And we'll say, well, where do you go when you have a migraine? I go in my room. The lights on or off? They're off. That's light sensitivity, okay? Then E is, of course, not better accounted by some other diagnosis. In other words, it's not going to satisfy migraine's diagnostic criteria if it's not migraine, right?
And you had mentioned kind of the timeline there of migraine attacks.
Yeah, I think that something that we have learned a lot more about is that migraine exists in different phases. It's helpful to think of migraine as having different phases of the disorder. The painfully obvious pain phase is the headache phase listed on the third column there. A quarter of migraine patients are capable of also having an aura phase. Raise your hand if you've ever heard of what a migraine aura would be like. So, that's a lot of hands. Mm-hmm. And so typically A migraine aura would be a visual one, an evolution of changing, evolving over minutes, visual complaints to one side or the other, or perhaps in the center of vision, where a person will see scintillations or lights or colors. Some people will actually see a kaleidoscope. There are interesting visual phenomena that happen that spread and evolve, and the person will generally not be able to see within the light or the visual phenomenon that's occurring. Only a quarter of migraine patients are going to be capable of having aura. You only need to have 2 auras in your entire lifetime, and you're a migraine with aura patient. You can have 10,000 migraines with no aura and 2 with an aura. You're a migraine with aura patient. It is interesting that aura can produce any symptom your brain can produce, which means aura can produce essentially any symptom you can think of. But it tends to just produce the visual symptom. The second most common migraine aura symptom is an evolution of hemibody numbness. And the third most common migraine aura symptom is an expressive aphasia, where a person in the midst of the migraine has words that they can't get out. Something that I think we are starting to learn a little bit more about is actually the prodromal phase. Now, while a quarter of patients with migraine are capable of having the aura phase, actually most people with migraine have a prodromal phase. These are symptoms like irritability, a building neck stiffness, a smoldering building light sensitivity. There are behavioral changes that occur. People can be depressed. A really common one that confuses people is insomnia. A lot of people think, well, I had trouble sleeping last night and that's why I have my migraine today. But realistically, oftentimes it's the reverse of that. You had trouble sleeping because you were in your migraine prodrome and the migraine process was already unfolding. The prodrome can last hours to as much as a day or 2 before the pain phase will occur. And then the postdrome that we'll call or often refer to as a migraine hangover. And so oftentimes patients will be just washed out, could be sleepy, very fatigued, after a migraine event has, the pain phase has finished. And so we know the most about the pain phase. We have learned a lot. There's still a lot that we don't understand about aura. We know very little about prodrome and postdrome, but we are learning a lot more about those different phases.
And the scary thing about aura, because we'll see that a lot through the emergency room, because some of the symptoms you mentioned, aphasia, not being able to get those words out, numbness and tingling, as we all learn more about warning signs of stroke, we're seeing a lot of those patients go to the ER. And sometimes they're not getting that follow-up, and they're like, oh, you don't have a stroke, go home. It's like, what about the migraine?
Yeah, in the way it's the way to really differentiate the two, stroke and TIA are precipitous maximal at onset disorders that don't really evolve much. When we block a blood vessel in our head, boom, all of the symptoms are there instantaneously. Migraine is an evolving disorder. The visual phenomenon evolves over minutes, generally lasts 10, 15, 20 minutes, perhaps as much as an hour. If the numbness is something that the person experiences, it will very commonly evolve in the same way. It will spread. A person will literally feel it walking down a portion of their body, and that will be after they had the visual symptoms. And then the expressive aphasia component of it will happen then 10 or 15 minutes after the numbness symptoms have happened. And generally it occurs in that way. Then also, if somebody would have numbness or expressive aphasia as an aura symptom, they will also have had visual aura in their past. And so that's an important clinical point as well.
All right.
So pathophysiology is something that just really refers to what is it that we understand about physiologically what's happening in our brain. When you would have gone through and I would have gone through training, they would have just called it vascular headache.
Yes.
Right? Just because of the throbbing and the evident dilatation of blood vessels that we have always assumed is responsible for the throbbing component of migraine. One interesting thing is if you really try to carefully investigate whether the throbbing symptom coincides with the pulse, it does not. Yes. And so we actually have learned a lot about what we call our trigeminal vascular system. We have a cranial nerve called our trigeminal nerve. It supplies essentially everything from our neck up, including our intracranial vasculature and the lining of our brain, the meningeal lining of our brain. And what we don't understand is really what's the first step that gets this system activated. It is something that starts with trigeminal activation. Exactly how that begins is what we don't know, but once it has begun, then we understand that trigeminal nerves release a substance called calcitonin gene-related peptide. I think it's on the next slide.
So lots of real changes going on in the brain there.
And so over on your left is a little cartoon of a trigeminal nerve, and the little purple dots are this thing labeled CGRP, or calcitonin gene-related peptide. It is something that our trigeminal nerves release out in our meninges, the lining of our brain, and that self-stimulates those trigeminal nerves to then send pain signals back to our brain in a positive feedback loop that really just starts like a snowball rolling down a hill. And so it's been very exciting for us to learn about the pathophysiology and then start to devise specific migraine therapeutics that have been developed to very specifically block the function of this neurotransmitter calcitonin gene-related peptide.
And then can you talk a little bit about what, we're talking about treatments here, and what does the level A evidence mean?
So level A evidence is just what we're going to refer to as we've got a substantial amount of well-done studies, at least a couple of well-done studies, and that they demonstrate pretty clearly that the treatment is effective. The best evidence is a placebo-controlled, blinded, randomized controlled trial. And so if you've got a couple of those and a treatment seems to be positive, that's fairly strong pieces of information that the medicine we're talking about is actually effective, and we'll call that level A evidence. And then level B is just a step below that, and level C is like, hey, we think it's probably beneficial. It's got a weak study or two that back it up. And so this slide refers to abortive treatment. We have different, it's important with migraine therapeutics to think through the treatments and keep them in their respective buckets. And abortive treatments are treatments that are designed to abort the current headache that you have. If I'm developing a headache right now, I would like a drug X, Y, or Z, or one of these on this list. Please go away headache right now. That's what we mean by abortive treatment. And the other class that's important to pay attention to or think about is preventive treatments. Preventive treatments, well, we don't.
Keep going back?
Yeah. Preventive treatments we'll get to in just a minute. So here on our level A evidence, not all of the medicines with level A evidence that are abortive are listed here. But the purpose of this slide, and we don't need to go through all of these medications, over on your right, the triptan medications, you'll notice the generic medication there, the root all ends in triptan. Those were really kind of one of the first true migraine-specific therapies. Sumatriptan was FDA approved in 1991, and there are 7 triptans. All 7 of them are generic as well, by the way, and so they have been increasingly easy to obtain. DHE, or dihydroergotamine, is the parent chemical that the triptans were really derived from to try to make them more safe and have fewer side effects. One of the general points through these slides is for people to not necessarily write down or look at the specific names, but to just take the general point like, well, there's a lot of things on this slide. We have a lot of treatments, and a number of them are level A. The CGRP-based drugs, which have level A evidence, we'll kind of show later.
Yes,
Right.
and you'll notice as we go through the treatments that they're getting a little bit more specific for migraines, because we all know acetaminophen, Tylenol, aspirin, general pain medicines, right? But like Dr. Toenjes mentioned, the triptans, these tans on the other side, those are migraine specific.
Mm-hmm.
So we're going to go to the next slide and show you some more. So these are the level B evidence treatments.
I do think it's worth mentioning that over on the right side, a lot of these are nausea medicines, and the antiemetics, some of the nausea medicines. A lot of people have heard of Zofran or ondansetron. Notice it's not on the list. Ondansetron is a very good nausea medicine, and if somebody has a migraine, ondansetron really may abort the nausea, but it will never abort the headache. Some nausea medicines, compazine and promethazine or Phenergan, Reglan, which is metoclopramide, those medications are actually some of the most effective ways to abort a migraine, not just the nausea, they will abort the pain. And it's very specifically one of the reasons why if someone shows up in the emergency room with an intractable headache, which is approximately 1 in 10 people in an emergency room, one of the most important things that they're supposed to give you is one of these antiemetics, because they're not a narcotic, and they are very, very effective at aborting the pain of a migraine. That's always seems to me forgotten. All right. Then the level C evidence medications for abortive, I just point out that there are some narcotics on here, and then an oldie but goodie that's been around for a long time. The last one, butalbital, mixed with acetaminophen and caffeine. That is a medicine was called Fioricet. In the headache clinic, that medicine we refer to as the F word. One of the things that's true about abortive medications, acute relief medications, is if a migraine patient takes them too frequently, the medication will backfire on them, and in a slow, smoldering fashion, slowly, progressively increase the frequency and severity of the headache syndrome, and we call that rebound phenomenon or medication overuse headache. And Fioricet, the F word medication, is one of the most potent medicines at doing that. I'm not saying there's no use for butalbital containing substances in the headache clinic, but we always have to understand and respect the frequency with which we can use that medicine and stay away from progressively worsening someone's headache syndrome. And it turns out somewhere between 4 and 6 doses of butalbital containing substances in a month crosses that line and starts to be able to build the headache syndrome. And so when we see patients that are on 6 to 8 Fioricet a day, those people have a very serious medication rebound problem. And it's difficult.
I do see that a lot in primary care patients who come in who want refills of those medications because they've been on them for years, and they want at least 30 a month.
Yeah.
And it's very hard to convince them that there are better alternative treatments these days.
Okay.
Yeah, so let's talk about preventive treatments.
The goal of preventive medications now is going to be to take the overall frequency of the headache disorder and reduce that, hopefully significantly, and hopefully with either no side effects or tolerable side effects. I share with patients that will define what we mean by success with a preventive medication. And we define success as at least a 50% reduction in headache frequency, at least a 50% reduction in headache frequency, and either no side effects or tolerable side effects. And I think it's an important thing for patients who oftentimes have lost hope because they've tried a number of things and have not had success. We have a lot of medications where the likelihood of success, as I defined it, is high. And indeed, there are a number of medications that we'll kind of point out here where most people that initiate them achieve success in the way that I defined it, meaning at least a 50% reduction.
Yes. And just like we talked about in that first slide, there is no cure, but there are preventive treatments to kind of decrease that frequency, but keeping it realistic. Maybe a 50% decrease. We're not curing it.
Mm-hmm. So the American Headache Society has some guidance on when is it we should be thinking about preventive medications. I think it's a busy slide, but the easy way to think through this is certainly if somebody's having 4 migraine events in a month, if they're beyond that, we really need to be thinking about prevention. Or if the patient has significant disability related to their headache syndrome. One of the things that has been a little bit eye-opening through global burden of disease studies, it turns out that migraine is number 2 on the list of disorders that give us years lived disabled. It's only second to low back pain. And if I asked who in here has low back pain, everybody's hand is going to go up. Well, migraine is number 2 in terms of, for humans across the planet Earth. This is the number 2 disabling condition. It has to do with its sheer frequency. If you look at females in childbearing years, migraine is by far number 1. And so one of the focuses that's important is to pay attention to the headache syndrome's impact on a person's ability to function in their life. And if the headache syndrome has a substantial impact on the person's ability to function, it's appropriate to think about preventive medications.
Yeah, and I think that's important, the word syndrome, because if you think about that slide that we showed you earlier, we're talking about the prodrome and everything leading up, and that's 3-4 days of your life where you're not functioning at 100%.
And every once in a while, it's not the pain of migraine that is the disabling part. It certainly can be the vomiting. It can definitely be the every once in a while I'll see it be the postdrome or the hangover, where someone just doesn't have enough energy to even get out of bed for an entire day after the pain phase. And so sometimes the pain is only moderate and they can function through that, but they can't function through the postdrome. And so understanding how the different phases of a migraine syndrome impact a person's ability to function, I think is really important.
Yes, and that does relate to, you think 4 or more headaches, just 4 headaches a month, and I'd want to take a medicine every day to prevent it. Well, when that prodrome and that postdrome are affecting your week, then that makes a big difference.
The same sort of designation, preventive therapies of level A, we don't necessarily need to go through all of these. The CGRP-based drugs are purposefully not on this list, so there's even more that have level A evidence in terms of prevention. You'll see down at the bottom, onabotulinum toxin A, that is Botox. That is a common that we see commercials for. Up at the top, divalproex, that's a seizure medicine. Topiramate's a seizure medicine. Metoprolol, propranolol, and timolol, those are our blood pressure medications. So these are all medications that through the years, patients and doctors have figured out, when I use this medication, it really helps my migraine syndrome. They're not very specific to migraine's pathophysiology, though, and they've all been sort of accidentally discovered. It is a true story that when people, I would guess, just historically, mostly females getting Botox for cosmetic purposes. Also females, remember, 1 in 5 is a migraine patient. That when botulinum toxin was being used for cosmetic purposes, the migraine patients were coming back saying, hey, you guys need to study this because my headaches are gone. And it is FDA approved as one of our most effective preventive agents, but sort of accidentally discovered. And Botox or botulinum toxin injections for migraine is why I have to leave at a hard stop at 1 o'clock, because there'll be 20 people waiting in the clinic for their Botox injections because they need them. It really helps them. And it is one that you can make the statement, most people get success with this preventive measure as I defined it. Sometimes I think it is useful to understand the other things listed on this. Realistically, when we look at, if I place a patient on topiramate, for example, Topamax or topiramate, what's the likelihood that that person will achieve success? The answer is actually 20 to 30%. And so most people are not going to either tolerate or respond to our more conventional oral preventive agents in the past. And that has produced a lot of treatment failures, and migraine patients a lot of them have given up hope. But I just alluded to botulinum toxin injections, and our newer CGRP-based therapies, really do have a much higher rate of efficacy and better tolerance rates too.
Yes, yes, and some of those medicines, the hard part is convincing patients this is not a quick fix. You're not going to take it that first month and it's going to change your life.
Yes. Topiramate or Topamax studies were actually very well done, randomized controlled trials, and in their studies they're a good example of what you're alluding to. When you look at the topiramate trials, the first time point that treatment and placebo groups start to split is 4 weeks, so a month is when they start to split, and then if you follow the split, it keeps splitting for 18 months. And so it's a very slow, smoldering response that we do wait for, as long as the person's not having side effects.
Let's take a look at some more preventive therapies that are out there.
So the things that we list as level B, there are some really good oldies but goodies, and the purpose of this is not to review them all. I do think, but to just note that there's a lot. But I do think that it's worthwhile pointing out that there's a couple over to the right that are not really medicines. Riboflavin is vitamin B2. It does have some reasonable evidence, level B evidence in efficacy in migraine prevention, and that is not a medication. And magnesium. So those are supplements. The feverfew is an herbal thing, and so just because we run through medications and our discussions are heavily weighted towards them, there are ways to try to achieve success, certainly without things that we would consider a traditional medicine. Level C, I think everything on this list does have at least some weak evidence. Candesartan is a blood pressure medicine that folks in other countries would have actually on the level A category. But again, just the general point that there are a lot of medications in our medicine box. I think we can go by that one.
Yes, let's talk about the newer treatments out there.
Yeah, so the CGRP or calcitonin-related peptide antagonists. We have GPANTs, and so you see the generic name for all of these medications is going to end in GPANT, just like the triptans do. Rimegepant is Nurtec. You see Lady Gaga's commercials with that medication. That is the medicine that's actually being studied as part of the menstrual migraine trial that we have ongoing. Atogepant is Qulipta. You do see commercials with Qulipta. and Ubrelvy or ubrogepant. We aren't seeing Zavspret or Zavegepant, which is a nasal spray. That doesn't have any real commercials out yet. If you pay attention to the Qulipta commercials, the atogepant commercials, you'll notice that they'll give a marketing piece. They'll say a chance at headache freedom. And so while there aren't cures, there are reasonable percentages of patients that, as we initiate some of these medicines like Qulipta, they're literally capable of going an entire month with no headache. And they may have started with 20 migraine days in a month. And so the FDA lets them make that statement, the chance for headache freedom.
And you want to talk a little bit about like why this was so different from some of those triptans that we had talked about, those Imitrexes, Zomigs, those older ones?
There are some vascular risks that are associated with the triptans. They do bind to receptors that are on some of our blood vessels and make them spasm a little bit, and including coronary arteries and intracranial arteries. The spasm is very minimal. But there's at least theoretical vascular risks with the triptans. And those risks don't really exist with the gepants. They do not cause any vasospasm at all. They prevent the dilatation of blood vessels that occurs during a migraine, but that's very different than producing a spasm. And so we have thought of them as extremely well tolerated and very safe medications.
Yes, because a lot of times with the triptans, we weren't able to even use them in patients who had any risk factors for heart disease. The pharmacist would give us a call back, are you sure? This patient has high blood pressure, they have coronary heart disease already, and this gave us a whole new set of medicines to put in our toolbox as well. And this was exciting for us because Jacksonville Center for Clinical Research actually was involved in some of the studies that involve the calcitonin gene-receptor peptide antagonists before they were on the market. So that's always exciting for me to see those now be available to patients.
Yeah, we were part of a atogepant studies.
Yeah.
And a number of the self-administered injectable antibodies. And so there are other CGRP antagonist therapies that are preventive therapies. They are self-administered injectables that someone injects every 28 days. So it's not a pill that they have to take. And they are extremely well tolerated. They're listed over to the right. Aimovig, which was Arenumab, was the first FDA-approved CGRP-based drug, and that was in 2018. And the other four are extremely effective. I use them every day, all four of them. And all four of them, I can say the same statement in terms of, most patients get success, as I defined success with prevention. And it's nice for patients to have, a pretty substantial list. The CGRP-based antibodies, Qulipta and Nurtec or atogepant, Rimegepant, as well as Botox. Those are all our medicines that most people actually tolerate quite well and respond to very, very well.
Yes, and don't let the name monoclonal antibodies scare you. Many of you may have already experienced some of these with the cholesterol medications that are already on the market. It's kind of using the same, technology there.
Mm-hmm.
The Ditans.
That is a very unique medication. Its name is trade name is Rayval. It's the way to think of Rayval, which is not really, it's a Eli Lilly drug, but they're not really marketing it much at all. It's actually a really good medication. It functions very much like triptans, but it only binds to a very specific serotonergic receptor, and it produces no vasospasm whatsoever. So it's like a triptan that does not have the cardiovascular risk. It does make people sleepy, and the FDA required a recommendation that someone not drive for 8 hours after taking the dose, and I think that Eli Lilly said, well, we're not going to make that much money on it, so they don't market it, and you don't see commercials for Rayval very much. But it is an extremely beneficial drug that sometimes is the solution to somebody's migraine abortive treatment.
Let's talk about Botox.
Yeah. So one of the more common treatments for chronic migraine patients certainly is Botox, which the generic of Botox is onabotulinum toxin A. There are multiple botulinum toxins. Just Botox happens to be onabotulinum toxin A. It is something that's a procedure, though, and you see pictured the little dummy head down at the bottom, the little dots that you see on that head are the location of the injections for a migraine protocol injection. If you count them up, it's 31 injection sites and has been FDA approved for chronic migraine since 2010. And millions of people have been given this medication. It's been around a long time, decades before it was, a long time before it was even FDA approved for migraine, and as mentioned, is one of our most effective preventive treatments.
So each time one of your patients comes in, are they getting an injection at every single little red dot there?
Yes, 31 shots at
31 each time? Oh, cool.
Yes, and every 3 months.
Every 3 months?
Yes, and if my scheduling is such that they're going to be late by a week, believe me, they are complaining about it. They're beating the door down to come and get their treatment because after 2.5 months, it starts fading out and they feel their migraine syndrome coming back. And so nobody misses their Botox appointments. Nobody likes getting 31 shots in their head. And so the fact that anybody comes back at all is a testament to the efficacy of the medicine.
That is true.
As a matter of fact, in private practice, we never even needed to confirm Botox appointments. Nobody would miss their Botox appointment.
Do they have amazing foreheads?
We're not doing that. We don't do it for cosmetic purposes. There are a variety of other therapies where this is not an exhaustive review of migraine treatments. Down at the bottom, there are device therapies, neuromodulation devices that can be effective. A lot of people have heard about the Cephally device. They're difficult to use in the United States, mainly because we can't get insurance to cover any of this stuff, despite there being efficacy and safe. These are safe treatments. But just because even if somebody has literally been through all medicines and is really still struggling, there are still other treatment options that we really kind of haven't talked too much about. And the neuromodulation devices are, I think, really, really beneficial. And behavioral management. One of the most important things, I give a sheet on behavioral modifications that can be beneficial in migraine patients. Every new patient that comes in is going to get a handout on the kind of behaviors that they need to be paying attention to. And those kinds of changes, things like staying hydrated, not abusing caffeine, sleeping enough hours in the day. An important one, keeping your circadian rhythm the same, meaning going to bed and getting up at the same time every day, trying to get some exercise. These minor things can really dramatically impact headache frequency in a migraine patient.
Yeah.
Yeah.
And you just touched on those. I just want to have a question for you, Dr. Toenjes, in terms of memantine. Some of you may recognize this medication. We often use it for Alzheimer's.
Yes, it's FDA approved to improve cognition in moderate to severe Alzheimer's disease. That's its FDA approval. But there's some pretty good studies on its efficacy in migraine prevention and its mechanism of action. You would guess it may be effective. And actually, historically, and I know this may sound weird, before we got rid of the pregnancy class system of medications, memantine was pregnancy class B, so it was a migraine preventive agent that, at least theoretically, we would think would be safe to use during pregnancy. I've never done that, but that's actually it is actually true. So I would say the biofeedback and relaxation training. These are along the lines of sort of the behavioral modifications that we mentioned. Relaxation training actually has some pretty strong data in functioning as both abortive and migraine prevention. Yoga as an exercise specifically, seems to be pretty special in terms of its benefit for migraine patients. I've always thought that it's not just the exercise of yoga that's beneficial. Yoga includes some relaxation, and so I've always wondered if that's the reason why adopting a yoga habit, as long as you're careful with your neck and migraine patients, is a very, very good idea.
Is that the relaxation of the muscles that's giving the benefit there?
Absolutely, and that's what biofeedback
The biofeedback.
is. We'll just talk briefly about sometimes it's worthwhile for patients to actually kind of formally track exactly how often they're having headaches. I like the Migraine Buddy one, but there are a variety of tracking apps. A calendar is a
Regular calendar,
tracking app that works as well. But sometimes it's eye-opening to see really how often somebody's having headaches and how often they're taking medications, and those kind of tracking apps really do exist. And so I guess in conclusions, what I hope that people can take from this is an understanding of really how common migraine is. 1 in 5 females, 1 in 10 males. It is an extremely disabling disorder that we usually don't go to our doctor and seek attention or ask for help. And actually, usually our doctor does not ask us if we have headache problems. And so increasing awareness of the people sitting in the room and your family members that are around you. If you're aware of someone who has a significant impact in their life from a headache disorder, your job now is to educate them about the fact that there really are a lot of treatments and even treatments that we're still studying and that are on the horizon. Keep the thoughts about the different therapeutics, abortive and preventive strategies separate, and walk away from this understanding that there are actually a lot of therapies that we have in our toolbox to help mitigate the disabling brain disease that we call migraine.
Thanks for joining the MedEvidence podcast. To learn more, head over to medevidence.com or subscribe to our podcast on your favorite podcast platform.